Hi, I am presenting a case of total laparoscopic hysterectomy in a patient with a previously operated for a myomectomy. And also, she has underwent a left salpingo-oophorectomy. So, as anticipated in any patients with the previous surgeries, some amount of omental adhesions to the abdominal wall is released. On the left side, it was adhered to the left lateral wall of the abdomen. And once we released it, then we got the exposure to the pelvis. So this is some amount of adhesions that are present, omental adhesions present to the anterior abdominal wall near the umbilicus. It is very near to the uh, primary port. So once we release that, still some more amount of adhesions are anticipated, and they were seen near the left lateral wall of the pelvis. So once we, only after releasing this, now we are having a exposure of the uterus. We can see that on the right side, we are able to see the uterus now after releasing these adhesions. And there is also some amount of intestinal adhesion to the posterior surface of the uterus. So it is better to divide these adhesions in the avascular plane between the omentum and the abdominal wall, which is the faster way of releasing adhesions. So definitely, without releasing these adhesions, we should not pull them. Otherwise, some places they may be vascular and can lead to bleeding and stain the surgical area. So these are the some more adhesions that are being released. So now we are going almost very close to the left lateral wall. Now we are able to see the sigmoid colon adhesions to the posterior surface of the uterus. We can see the tinea coli is added. Once, if we release the tinea coli, now we can see some amount of sigmoid colon is also added to the left posterior surface of the uterus. So all these adhesions better to be divided in avascular plane. Should not be trying to pull it off and try to tear. Where a small amount of bleeding can lead to a staining of this area. So always reconstruct the anatomy before starting the surgery. Identify the structures like round ligament and then infundibulopelvic ligament, utrovesical fold of peritoneum. So these anatomy need to be identified and reconstructed as much as possible before we start doing the uh, dividing the pedicles. So this is the sigmoid colon adhesions, as I mentioned. It's seen adhering to the posterior surface of the uterus. Is being released now. So now I think a complete adhesion of the sigmoid colon is released. So better to use a traumatic grasper to hold the bowel and then release it close to the uterus. So all these reconstruction is very, very important before we start the surgery. So now you can see that though there was already salpingo-oophorectomy is done, so this is the adhesion band that is present between the lateral wall of the pelvis and the left side of the uterus. So in these cases, the fibrosis is seen, some amount of fibrosis is seen even in the retroperitoneal area. So we're trying to enter into the retroperitoneal area, identify the ureter, and then further dissection becomes easier. So identifying the ureter is the only way to prevent injury to the ureter, especially in a patient like this, whenever there is adhesions of the previous surgery. Slowly, we are trying to open the peritoneum, covering the sigmoid between the sigmoid colon and the round ligament. We are going deep down. So here we can see a band of tissue which appears like infundibulopelvic ligament, but actually it is a fibrotic band. But to be in the safer side, we are just identifying the ureter and then try to divide this band of tissue after confirming the location of the ureter. So this is the peritoneal adhesions near the anterior part of the uterus on the left side. So they are all thick and fibrotic, are not easily dividing it. So we are trying to identify the ureter on the left side. Once we can identify that, then the dividing of the peritoneum becomes more faster and easier. Where we can identify ureter by its peristalsis. So once we identify that, now it becomes easier from our side to divide the rest of the pedicles. So that is the round ligament we are able to identify and divide it. And there is a very loose cellular tissue is being divided by using a ligator. We identifying each and every structures, especially in the patients who have distorted anatomy, is very, very important. Before dividing them, we should identify what structures we are dealing with. Only if it is a safer structure, then only it should be divided. Otherwise, if it is the intestine, if it is the ureter or the bladder, so at least these important organs need to be identified and then they should be divided. So once we identify the ureter, now it is easy and safer to divide this band of tissue between the uterus and the left pelvic wall. Now we can further continue the dissection towards the uterine vessels. So that is the utrovesical fold of peritoneum. It is advanced near to the round ligament on the left side. So as we always remind that any fat is present near the bladder is always belonging to the bladder, and the fat near to the rectum is belonging to the rectum. So keeping that in mind, we are going to divide proximal to the fat plane and keeping it laterally, keep the fat laterally towards the bladder and try to identify the plane between the uterine vessels and the bladder. We are trying to identify the plane between the bladder and the cervix so that it can be separated. Here in this patient, there is a doubled up folding of the bladder onto the anterior wall of the uterus. In the superior surface is also folded back onto the body of the uterus, and the base of the bladder is always there, attaching to the lower part of the cervix and upper part of the vagina. You can see, so this loose cellular tissue is also fibrotic. It's not giving away very easily. It needs to be separated, divided, and then only it can be separated. So these are all thick band of tissue that is fibrosed. Now we're trying to start the dissection from the right side. In the right side, we can see there is a ovary is present. The fallopian tube is also present. We are trying to preserve the ovary on the right side and start the surgery by doing ovarian ligament division, as this is more exposed than the mesosalpinx. Otherwise, you would have started with the round ligament and then gone back to the infundibulopelvic ligament and mesosalpinx. Here we are starting with the division of the ovarian ligament and then division of the mesosalpinx. Then we'll go ahead and divide the round ligament once these two pedicles are completely divided. So we can see this once the infundibulopelvic ligament mesosalpinx is divided, we can see that advancement of the bladder doubled up. There is superior surface of the bladder. It's not the base of the bladder that is onto the cervix. It is the superior surface of the bladder that is folded onto the anterior surface of the uterus due to the adhesions. It's not a normal location that is being separated and then it is divided. So even on the right side, we are trying to identify the plane between the bladder and the anterior surface of the cervix. Round ligament is very much thinned up in on right side and separated it is not identified. So this is the posterior fold of peritoneum near the round ligament. Now we are trying to open the utrovesical fold of peritoneum, trying to separate the bladder from the cervix. So now we can see here, we can see some amount of loose cellular tissue which is being identified and trying to separate the utrovesical fold of peritoneum away from the cervix so that we can complete the process of hysterectomy. So this you can see loose cellular tissue is present. So that is in the left hand I'm holding utrovesical fold of peritoneum. Along with that, bladder is also pulled up and it is being separated from the anterior surface of the cervix. And we're trying to divide it. So we continue the dissection from right to left side. The utrovesical fold of peritoneum, which was doubled up and it is folded back onto anterior surface of the uterus, is divided and completely we are trying to separate the bladder from the cervix. And these are all fibrotic bands. So normally once you divide the utrovesical fold of peritoneum, the rest of the separation is easier. But here it is fibrotic and it is adhered. So without division, the tissue is not separating. So instead of doing a blunt dissection, it's better to go for a sharp dissection and identifying the plane of avascular plane and then dividing the fibrotic band between the bladder and the cervix. And every time we have to confirm we are not dividing the bladder at this junction. So every time we are doing a blunt plus sharp dissection, a small amount of blunt dissection and then sharp dissection, but keeping the avascular plane. So that is the avascular plane is kept in our mind. We can see significant amount of bladder dissection is done. Still, we are not reaching the cervix area. So now we are dividing the posterior leaf of rod ligament on the left side. We are trying to identify the uterine vessels. So even in these cases, the uterine vessels will be more tortuous and they are very fragile, especially the uterine veins. They need to be identified, sealed completely, and only then it should be divided. Otherwise, there will be not only significant amount of bleeding, also it will soil the surgical field. So we can see this fat plane is getting separated from the cervix. So now we are reaching the uterine veins. Should be careful, should be coagulating more than dividing them. Slowly we are continuing our dissection in the left side near the isthmus. So now we have came very close to the site of the uterine vessels. So we are using the bipolar energy source to seal the uterine veins and uterine artery before it is being divided by using a ligator or shearer. So after completely sealing the uterine vessels, now we are trying to divide them. So better to completely seal the uterine vessels, especially in a case like this where we anticipate a tortuous and multiple vessels because of the previous surgery and because of the fibroid uterus. These may become more tortuous and better to seal them completely and then only you should do it. Otherwise, it takes more time or more amount of bleeding will happen if you try to seal them after they start bleeding. You can see even after sealing them, they are going to bleed. So better to identify them, seal them completely, and adjacent vein need to be sealed, and then it should be divided by using the shearers. So that is the uterine artery just will be divided. Now we are going near the cervix, and still some amount of uterovesical fold of peritoneum or bladder and the cervix need to be separated. So that we continues as we continue to dissect the uterine vessels and continue the dissection medial to uterine vessels. That prevents injury to the ureter. So we can see that we are coagulating more than dividing them. So that is very, very important, and wait for some time before dividing the vessel. Coagulate and then keep it for some time, and then you try to divide them. If any vessel is bleeding, better to be identified and then coagulated immediately. We can see now we are able to divide the uterine artery. We coagulated it, waited for at least 1 or 2 minutes, and by that time we are dividing the other part of the surgical area. And then once we give enough amount of time, once you satisfied that vessel is completely coagulated, only then we are going to divide it. You can see cervix looks little broader. Cervix is little hypertrophied. So now we are coming near to the cervix. Uterine vessel is divided, isthmus is separated, and then anterior fold of the bladder is also being separated from the cervix. Base of the bladder is being separated from the cervix. So we are almost completing the dissection on the left side, going well below the site of the cervical area, and we are coming very close to the uterosacral ligament, which is the final dissection point of the left side. So once this is complete, now we can continue the dissection on the right side. And then complete the similar process will be done on the right side also. So once you identify uterosacral ligament, that is the final. Right? No further dissection is necessary below the uterosacral ligament. Seeing that, we can see that there will be opening of the vagina now. You can see there is a vagina is opened. Now we are into dissection on the right. On the right side, at the level of the isthmus, there is a small fibroid is present. It's around 2 into 3 centimeter fibroid is there, which is covering the uterine vessels. So, and the uterosacral ligament is pulled well away, well close to the cervix, close to the isthmus of the uterus. The uterosacral ligament is pulled up due to the small fibroid, intramural fibroid at the level of the isthmus. Here, the blood vessels will be pushed either anteriorly or posteriorly. Sometimes the vessels will be below the fibroid. Sometimes the vessels are anterior to the fibroid. In this case, we can see the vessels is seen anterior to the fibroid and is being coagulated, and then it is divided. So that is the vessel we are trying to coagulate and then divide. So once it is completed, then we can again continue to do the dissection of the lateral part of cervix. So this is the vessel in the uterine vessel anterior to the fibroid near the isthmus. Now that is the uterosacral ligament. We are dividing it. That is pulled well above the site of the uterine vessels. So normally we see uterosacral ligament well below the site of the uterine vessels, but here in this case it is pulled well very high. So that may be the reason why we are able to identify that uterosacral ligament little superior to uterine vessels. So now, even on the right side, the surgery is complete. Now the job that is left is just to divide the cervix from the. So we can see that initially we had already opened the vagina on the left side. So that we are going to complete the process of transecting the vagina from the cervix. That is the vagina. We are going to separate it. And then we are going to divide it, complete the transection using a ligashoe. Complete the dissection by using a sharer, bipolar sharer. We are using it. So this how completes the surgery of hysterectomy. So though uterus size was small, it was just an 11 centimeter fibroid, 11 centimeter uterus. But because of the previous surgery, the anatomy was distorted. So we had to complete the dissection before we started doing the surgery. So now we are just approximated uterosacral ligament back to the vault of the uterus, and that's so we are completing the process. So in any patients with the previous surgeries, you can anticipate some amount of adhesions, distortion of the anatomy, and more vessels need to be coagulated before dividing them. So that should be kept in our mind. That is the most important principle we should be keeping in our mind whenever you do surgery in a patients with the previously operated cases. And we can anticipate some amount of intestinal adhesions, bladder adhesions, or medial mobilization of the ureter. All these needs to be identified. So once we identify these three important structures, now we are left with the dividing the ligaments, round ligament, infant or pelvic ligament, or ovarian ligament. then uterine vessels, and finally the transcervical ligament. Once you divide transcervical ligament, the next ligament will be left will be the lateral ligament or fan-shaped ligament. The final is division of the cervix in the vagina. So now we divided the right, just ligated the right uterosacral ligament, and the right part of the vagina is closed. And then one will take one more stitch from the center, and then from the left uterosacral ligament, which will be attached back onto the vault of the uterus. So this is the video me demonstrating the doing surgery in a patient with the previously operated cases where anticipating some amount of adhesions, distortion of anatomy. So before continuing the surgery, better to reconstruct the anatomy, identify each and every structures before dividing them, and whenever possible, identify the ureter and then bladder. Thanks for watching this video. If there are any doubts, please put it in the comment box. I'll try to answer them.